Hello, my name is Jordyn Ewbank. I'm one of the senior residents at Christus Health Texas A&M Emergency Medicine Residency in Corpus Christi, Texas. The title of my study is Hand Sanitizing Products, Impact on Breathalyzer Results in Sober Adult Volunteers. I'd like to thank my co-authors, Drs. Richmond, Shu, Leeson, Torres, and Miller. I have no financial or non-financial disclosures. By way of introduction, first we'll talk about breathalyzer use in the emergency department. As we all know, alcohol use and intoxication are common among ED patients and can influence the care these patients receive. Breathalyzer machines are often used in EDs as a rapid screening tool to assess for alcohol intoxication, and more commonly by law enforcement officers. Alcohol use has significance in both clinical and legal settings, and therefore errors in breathalyzer testing are not inconsequential. Investigators have reported that breathalyzer findings in the ED can be inaccurate for a variety of reasons. Prior studies have looked at distortion of breathalyzer results due to several factors, including alcohol-based mouthwash, alcohol-containing hand sanitizer, asthma inhalers, and non-alcoholic energy drinks. It is not unreasonable to assume that breathalyzer results may be similarly affected by the application of other products frequently used in healthcare settings and by law enforcement. This study aimed to further explore this possibility by determining whether the application of hand sanitizer lotion and insect repellent has a significant effect on breathalyzer results. Our objectives were to determine whether the application of alcohol-containing products to the hands would influence breathalyzer readings. In terms of methods, this was a prospective, controlled trial performed at an urban teaching facility, including healthy, consenting volunteers. Inclusion criteria included individuals aged 18 to 75 whom were willing to participate and verbally consent. Those were excluded if they were unable to consent, if they had an initial breathalyzer reading greater than 0, or if they had consumed alcohol or used alcohol-containing products within the previous 12 hours. Our protocol was as follows. Subjects received training in the use of the Backtrack SAD breathalyzer, and baseline BAC readings were obtained. The subjects were then instructed to apply the first of 3 different alcohol-containing products to their hands. The first was a consumer hand sanitizing gel containing 60 to 70% ethyl alcohol, such as Purell or Germex. The second was a healthcare sanitizer gel with moisturizer containing 61% ethyl alcohol. This was 3M Avogard D, commonly used in operating rooms. And the third was alcohol-containing insect repellent, which was off, and also DEET-containing. Immediately after product application, a second BAC reading was obtained prior to thorough drying of the product on the hands. If this second reading was greater than 0, a third reading was then obtained after thorough drying of the hands. Subjects then washed their hands, and once the BAC readings returned to 0, the process was repeated using subsequent products. To clarify, each subject tested all 3 products, and breathalyzer readings were obtained for each product, including the initial baseline reading, a second reading after product application, and a third reading only if the second reading was positive. Regarding statistical methods, categorical data are presented as frequency of occurrence, continuous data are presented as means plus standard deviation, and 95% confidence intervals were calculated. Next, our primary outcome parameters were to assess for positive breath alcohol readings that were greater than 0.08, which you would recognize as the legal driving under the influence threshold in many states, and also for readings greater than 0.04, which theoretically could put one at risk for nearing the legal threshold if they had a combination of hand sanitizer application and alcohol ingestion. Now for our results. 51 subjects were enrolled, 49% female, 51% male, with a mean age of 31 plus or minus 6 years. None of our subjects reported significant alcohol ingestion within the preceding 12 hours, and all had a baseline BAC of 0. The mean BAC readings were calculated along with the standard deviation and confidence intervals. For the consumer hand gel, the mean was 0.03 with a standard deviation of 0.024. For the healthcare sanitizing gel with moisturizer, the mean was 0.024 with a standard deviation of 0.021. And for the DEET insect repellent, the mean was 0.004 with a standard deviation of 0.009. None of our subjects had readings greater than 0.08. However, some subjects did have readings greater than 0.04, including 12 of them from the consumer gel group, 8 from the sanitizing gel with moisturizer group, and 0 from the insect repellent group. Continuing into our discussion, we'll start briefly with breathalyzers. As you know, they are devices which are used to estimate blood alcohol concentration by measuring alcohol in exhaled air, and this is by way of Henry's law. As with any man-made machine, breathalyzers inherently have potential for error. For example, they can detect interfering substances, and there can be errors in calibration of the machine itself. Foglio-Banda et al. Investigated the effects of alcohol-containing mouthwash on breathalyzer results. They took breathalyzer reading from subjects immediately after mouthwash rinse, represented by T0, 10 minutes after mouthwash rinse, represented by T10, and 20 minutes after mouthwash rinse, represented by T20. They found statistical significance between average BAC readings at T0 and T10. These high T0 readings were thought to be due to residual ethanol in the oral cavity. Lindsay et al. Investigated the potential for anesthesiologists to have a positive BAC reading when following recommended hand hygiene using alcohol hand gel while at work. 8 of 130 breathalyzer readings they obtained were positive. 5 of those positive results returned to 0 in less than 7 minutes. All of their subjects had blood alcohol levels obtained, and all of which were negative. They hypothesized that the positive test results probably arose from inhalation of alcohol vapor into the respiratory dead space following gel application. Ali et al. Investigated whether the use of alcohol-based hand sanitizer used by the person operating the breathalyzer machine would affect the results. Their participants were divided into groups, including one group which allowed the hands to dry fully after application, and 2 groups not allowing hands to dry fully using 1 and 2 pumps of sanitizer respectively. Differences between each sequential group were found to be statistically significant. Investigators concluded that alcohol-based hand sanitizer may cause false positive readings even when the operator uses the hand sanitizer correctly. Breathalyzer readings were further elevated if more sanitizer was used or if it was not allowed to dry properly. Bruce et al. Investigated the effects of hydrofluoralkane ethanol metered dose inhalers on breathalyzer results. They found statistical significant increases in BAC immediately after inhaler use, both in asthmatics and normal subjects. There was no statistical significance 5 minutes after inhaler use. Therefore, they concluded the effects of the inhaler use on the BAC was transient and negligible 5 minutes after use. Lutmer et al. Investigated breathalyzer readings after volunteers consumed non-alcoholic energy drinks, some containing low concentrations of ethanol. Their subjects had positive BAC readings after consuming 11 of 27 different beverages when breathalyzer readings were taken within 1 minute of the end of drinking. In contrast, their subjects had BAC readings of 0 after consuming all 27 beverages when breathalyzer readings were taken at least 15 minutes after the end of drinking. In regards to our study, it corroborated previous study findings that alcohol-containing products can cause false positive elevations in BAC. Our study was novel in that we used alcohol-containing hand sanitizer lotion and insect repellent commonly used in healthcare settings and by law enforcement, respectively. Now let's consider the limitations of our study. It was a single center study with relatively low sample size of 51 subjects. We used the Backtrack S80, which is a commercially available and relatively inexpensive breathalyzer machine when compared with breathalyzers used by law enforcement officers, and it may therefore be considered less reliable. And lastly, we were unable to enroll individuals who recently consumed alcohol for comparison to sober individuals. In conclusion, sober volunteers had low BAC readings following application of several alcohol-containing products. Some subjects had levels that, when in combination with low volume alcohol ingestion, could result in levels above legal threshold for impairment. Awareness of this study can help ED providers interpret BAC results in the clinical setting. Thank you.